and that's why we picked the United Medical one, right?
Okay.
So we are live. You need to actually just go to the channel there.
Yeah, it does look like it's on there.
You know, the people that I watched on YouTube, they all had the same problem, so it's okay. So it seems like
Part of the process.
we are live. So what we'll do is, if George and other people in our company, if you guys can please send the new link for our event. So then we'll start in a minute. George, will wait then okay from you? Okay. Okay, so we sent the new link to everyone, and I'm hoping that everyone is able to see what I'm seeing. If not, next time we'll do a better job. And I got a couple messages saying that we are okay. And thank you for everyone waiting for us. Today is the last day of April 30th, Friday, our weekly session. We are here with you from United Medical with the different updates that we have. Starting from COVID and vaccination updates, my business development resource, Tanner Fuchs, is with me as usual. And then later on, Carlos Manhart from our revenue cycle management team will be here. And then we'll be back to our other discussions on the issues with the healthcare and quality and cost. And we'll have some messages for our patients, for our employees, and mainly for our lawmakers in United States and especially in the state of Delaware. So Tanner, we can actually start with you. I'm going to start sharing my screen.
Sure.
And
okay.
Go ahead.
Sure, thanks, Kemal. Wanted to go over some of our routine updates first and foremost as it results to the COVID vaccine and COVID administration across the nation. So something we're keeping a close eye on is the path towards herd immunity, which is going to be accomplished with higher rates of vaccine administration. We've been kind of hovering around that 3 million mark, and we're progressing upward. We're seeing a little bit of a continued dip in the amount of administration of vaccines in the United States, as well as in the state of Delaware. You can see the graph on the top here showing the United States, whereas we're looking at just the state of Delaware on the bottom. Now, the state of Delaware is a little bit ahead on pace in the amount of vaccines that are being administered on a rolling 7-day average or a daily basis, as opposed to the average in the United States. So Delaware currently still on a 2-month trajectory to get to 75% of its state population, whereas the United States is on about a 3-month trajectory right now to get to 75% of the population. So could, again, as we kind of discussed prior, this could be some vaccine hesitancy towards getting administered or getting the dose of the vaccine, thanks to the issues we saw with Johnson & Johnson and kind of the media coverage around that. This also could just be seeing a little bit of a delay in the actual pause of the Johnson & Johnson vaccine. So a number of different factors that could be causing this. We're also starting to get into populations of people that are going to be more hesitant in general to get administered the vaccine. So we'll keep an eye on this, but we do want to just note that our dip is in the vaccine administration is there for the United States, but it's not necessarily affecting our rates per immunity just quite yet. So overall, the administration of the vaccine for a little bit was, as you can see here, against the amount of cases per day on a rolling 7-day average as well on the bottom here. We saw a large drop off with the onset of the vaccine administration, which was great news. We did see a slight uptick in it, and that could have been to a number of different things. That was right around the spring break time. A lot of people, weather was getting warmer, people were starting to get out and start doing more things as things started to open up. And we were a little concerned about that, although we did discuss how this is nothing to be super surprising, as the vaccine, although it's the great a tool to get us back to normalcy and to a state of herd immunity against the virus. There are going to be some ups and downs here ever so slightly, as we still, of course, have a large part of the population that's not vaccinated, as well as the vaccine isn't 100% effective in preventing the vaccine or preventing the virus. Sorry. So we did start to see a little bit of an increase there in their cases, but that average is starting to go back down, which is good news. So as I kind of alluded to, we've been keeping an eye on the Johnson & Johnson pause as they started to kind of take a look at some other cases of whether or not this issue with the blood clotting was related to the vaccine. As you remember, it was a very, very, very small percent of cases that were experiencing some sort of blood clotting after getting a dose of the vaccine. So the pause was just to kind of take a look at some more cases, see if this is something that they were actually going to be able to link the causation to. We have gotten the okay from experts, the CDC, FDA, to resume the administration of the vaccine. And so far, we are starting to see that get rolled out again across the nation. And thankfully, it does seem that people are pretty receptive to it and still willing to get the vaccine. We were hoping that that wasn't going to really hamper the administration for not just the Johnson & Johnson vaccine, but all vaccines in general. So it's good news to see that this is coming out of the CDC and the FDA. And I'm hoping it does kind of revive some trust in the vaccine.
So Tanner, today, we actually decided that we were going to do a little bit less time on the vaccine. The problem is, okay, so right now, one of my best friends is calling me on YouTube when I'm on live. So I'm assuming that he's not watching. It's okay. So next time I'll out him. So what's important for us is that what we were saying, that we were going to spend a little bit less time on the vaccine. However, what I want people to actually remember and understand, and we are not trying to scare anyone. We don't know, right? What's happening today is we don't know. So if you don't know what's happening, then everything that's known and everything that's available, then we have to be able to share those news with our people so that they know. So although I was kind of editing your, part of your PowerPoint for today, but this is something that I want to actually share with our people. These are pictures from India these days. What's coming out of some of the news is coming out of India is not really. It's difficult to watch. So I'm hoping that we understand. So why I had to kind of interject here, Tanner, is this J&J issue. In my opinion, it was a big scandal because it stops the process of something that's going to help people. Now, many people, they're like, oh, nothing is going to happen. We are just exaggerating. Right now, there are so many people dying in India, and they don't have some basic needs. Although we live in the United States, we have responsibilities overall, what needs to happen. So, and I'm upset in a way that J&J issue is not handled properly. And the reasons, because there's only 6 bad outcome, which is 0.08%. That should really not stop the process, and then at least other countries can use these. I'm hoping that mistake won't be repeated again.
Mhm.
So
Sure.
you have one more slide, right?
Yeah, just one more slide. This came out this past week. I'm sure this has been in the news, and I'm sure everyone at this point is pretty aware that the CDC is starting to ease some of the guidance for mask use in vaccinated Americans. So this past week, they recommended that vaccinated people while outside should be able to go maskless, especially while they're by themselves. But also, I believe this was in small gatherings, small groups of like friends, family. And the one thing that they did want to note is this isn't necessarily something you want to be doing, though, still in crowded places. So although you're outside, transmission is going to be cut down pretty drastically. When you're in large crowds, that's still something to be mindful of. So just wanted to pass along this update as well for anyone who might not have seen or been aware.
Tanner, thank you for our corona vaccine update. So we are going to ask Carlos to join us. Carlos did have a session with me before, right, Tanner?
I don't know if we had a live session, but
Yeah,
I've been
I think so.
in a couple of sessions.
So Carlos is my younger version in United Medical, right? So Carlos, you are one of our senior client managers, right? Since 2014, you've been with us. So what we wanted to do, take an advantage of these live events, and while we are communicating with our patients, our employees, we also wanted to communicate with our clients and prospect clients as well. So as the only authorized user of Cerner SPM practice management system in the ambulatory setting, so it's kind of our obligation to tell people what we do. And last week we did the collection module of the SPM, and then today Carlos is going to walk us through with the reporting piece. So if you're a medical office and if you're a provider looking for the SPM transition, this would be the time for you to watch some of our videos, and we are also available for Zoom meetings for those providers. So Carlos, I'm going to actually turn this over to you.
Sounds good. Thank you, Kemal. And yes, you mentioned I'm one of the senior client managers for the RCM team here at United Medical. And I'm going to be reviewing some of the reporting capabilities that SPM has and how we use them to run some of our day-to-day tasks, and also to provide feedback to our clients. So as you mentioned, or as you might know, Kemal, SPM offers a variety of reports depending on the needs that the different providers have. However, today we just wanted to focus on the three types of reports that we use most at United Medical, which are the daily reporting, the monthly reporting, and the reporting that we do on the scheduling side. So another thing that we wanted to introduce in this meeting was QuickBase, which is an application development platform that we use on a day-to-day basis to do pretty much everything, from tracking our daily productivity in our departments to managing a variety of projects. We also gather all the information that we get from our PM systems, and we upload it into QuickBase to run some of our reports that we then provide to our clients.
So now the QuickBase is our business database. So we have different PM systems. In fact, right now we have 3 different PM systems, but we needed something like QuickBase for us to do certain things. And we were only able to do that at certain scale. So obviously 15 years ago, we didn't need it, but when we have more needs and complex businesses that we deal with, complex specialties that we deal with, so it was important for us to have an add-on business database. So right now we master QuickBase in a really high level, where we are able to customize based on the changes that's happening in the healthcare. So now these reports you are going through, like these, some of them are hard-coded reports, right, Carlos? So tell us what's going on there.
Correct. Yes. So here we have a couple of the reports that we run on a daily and monthly basis. Kemal, the one on the left is one of the reports that we use the most. Is used the most by our RCM team. This report is run on a daily basis to track the claim corrections that we do on the AR side, and we also use it to track our total payment amounts posted. The provider offices can also use this report to track charges, payments, and adjustments based on their needs. The report on the right side is the report that we run every end of month. And that report is used to track all the financial related items for the month for the provider's office. And it includes CPT counts, charges, payments, adjustments. And as you can see, it's very customizable. You can run procedure codes, the procedure codes that you want, specific categories based on the specific setup that we have for that practice. So these are two of the reports that we use the most on our end. Kemal, if you want to go to the next slide.
Yep, I just need to delete what I put there.
That's fine. This report is, the report on the left side is the scheduler report. It's reports that we use to track the appointments. And again, it can be customized based on the provider needs. I started getting more familiar with this report as the COVID-19 pandemic started, as we started using it to keep track of the practices that had a decrease in the number of appointments. And it kind of helped us identify which practices were staying a little bit behind with the number of appointments. And we try to push those practices to use telemedicine a little bit more. And
I think with having so many different specialties, we have right now, about 22, 23 different
23 different specialties.
That's important for us to utilize reports in, like the scheduling reports in different.
Correct. And on Kemal, if you want to go back to the previous slide, I just wanted to point something out really quick. With the different specialties that we have, we understand that each specialty requires a unique setup. So we kind of have to adapt the way that we do the reporting for those practices, for some specialties. There might be some specialties like nephrology, a nephrology practice that they might need to see a report for a specific CPT code that a cardiology practice might not need.
Monthly dialysis report maybe, or
correct.
Home dialysis. And then certain things needs to be done in a way that this is not what it used to be, where the physician's family member works as an office manager and they can do the check in, check out and the billing when they have a little bit more time. It requires a high level education, and just so that we understand this is the revenue cycle management, not just simple billing claim process.
Correct. And we wanted to show a few of the reports that we share with our clients on a monthly basis. So if you want to go to the next slide, Kemal. So here we have a couple of them. This is the denial reports. This the first one on the top. It shows the corrections. This is one of the reports that we share with our clients, and it shows the corrections for the previous month, the corrections that we made on our end, the RCM team. They go through the claim corrections and have these claims resubmitted. As you can see on this report, it's broken down by preventable type. So depending on the source of the denial, we categorize it and then we summarize it at the end of the month for the clients to see. As you can see here, we see a percentage for the previous month for this client. There was 50% of the corrections that we made were related to client preventable denials, mistakes that could be prevented on the office end. And if you see from January to March, there's been a constant decrease on these practices percentage in the client preventable denials, which is kind of what we're looking for. And again, we go through these reports on a monthly basis and try to provide our clients with feedback based on the type of denials that we're seeing.
So now I do want to make sure that we kind of explain this a little bit more. So these are our internal metrics, like internal categories. No one in the United States is utilizing these the way that we are utilizing them. So I actually established these in the last several years. So behind each of these numbers, there's a denial code attached to it. So this 335 is not we are not seeing that number in that comes, that's a summary report. So then it represents 335 different corrections. So the idea is for us to be able to tell this client, this actually is United Medical Clinic, if I'm not mistaken. So we categorize them as, it's an office-based PCP. Why do we say office-based? Because there are some PCPs, they still go to the hospital, and in their denial comparison, Carlos, the issue of comparison is extremely important. Why? Is because you can compare, like the classic, like the apples to apples or apples to orange. Like being able to compare similar, same time period, same everything. Like, for example, year 2020 is not going to be the year that's going to be compared to any other year because we have the pandemic, right? So when we say compare, we want to be able to compare the client with United Medical standards, with MGMA standards. Then we also want to compare them with their own peer averages, same type of group. So then these numbers would become more meaningful. Otherwise, you are just comparing apples to oranges, and guess what? They're going to be different.
Correct. And if you can see at the top of that report, Kemal, we have the average for the office-based PCP. That's where we can kind of like show the client where they stand. It's 52.5% client parental denials. It seems for the month of March, for United Medical Clinic, the number of that percentage was lower, which is what we're looking for.
Right.
Now, the report on the bottom side, Kemal, it gives you a break. If you want to go back to the previous slide, the report on the bottom side for the previous slide is it gives a breakdown of the client preventable denials by check-in, check-out, or office administration. And again, this is a summary report. And like you mentioned, each one of these denials codes that we have an origin, have a preventable type, and these reports allow us to break it down and identify where the issues or where the denials are coming from. So again, the majority of the denials and corrections that we made for this client during the month of March were coming from check-in related denials, which could be anything that's related to insurance eligibility, incorrect IDs being entered. Then 34.8% of the denials that we were seeing were related to checkout related denials, which could be incorrect place of service, incorrect CPT, incorrect diagnosis. And we use this to provide feedback to our clients to based on what the issues are. Again, this is report. It's even more detailed. It has the information on the denials and each specific denial. And now, Kemal, on this one, you can stay on this one.
Yeah, I did go a little bit too quick because, go ahead.
Correct. Yeah. So on this report, again, it's just broken down by each of the specific denial codes that we entered for that time gap, that time frame. And one of the main things that caught my eye when I was reviewing this report is one of the main issues that we had during the month of March for this specific practice was the COVID vaccine related denials. We have an issue in which there are some claims that are being billed for COVID vaccine that are being billed directly to a Medicare HMOs. These insurances don't accept those claims to be billed to them directly, and we have to bill them directly to Medicare. But again, yes, these are the correction codes. It's the list, and it just gives you a better detail of what's happening with the practice. Yeah, no.
So this is our trademark reports, and I just want to make sure that we put a disclosure out there so then we do not want other billing companies, RCM companies to copy these. These are trademark of United Medical LLC. So I just want to point that out.
That's good. Kamal, you want to go?
You have one more report, right?
Yeah, I have a couple more reports, and I just wanted to review quickly. These are charges and payments report. Again, we pulled this information from SPM, and we adapted and upload this information into QuickBase. And again, it just gives you a breakdown by month of the total payments, charges, and adjustments for both years. Again, these reports are fully customizable, and we can adapt them to the provider needs. It shows the total, like you're pointing out at the bottom, for both years. And the report on the bottom side, again, based on the customizations that we have, it shows the charges and payments by provider. Now we blacked out the provider names for privacy reasons, but again, this will show the provider name and the provider types and the breakdown. I think this report is year to date, Kamal, so it gives the comparison 2020, 2021 charges and payments received for that specific provider. Correct. And I think we have one more report.
Can you see it? This is the type of service, right?
Yes, I can see it now. And again, based on the CPT
I think
code,
there's a slight delay, Carlos.
Gotcha. Yeah, there's this report again is based on the report class and the category of each CPT code. We gave a category and report class to each of the CPT codes that we have been uploading into QuickBase. And this gives you a breakdown by report class. And again, like I mentioned before, this report is year to date, and it gives you a comparison of both years, 2020 versus 2021, by the category of that specific CPT code.
So this was our second series of the SPM. So in the next couple of weeks, we'll have Beste crew. She's going to be back. Richa Sabason will be back. So we are going to be actually updating a couple other sections of the RCM through SPM. Again, the SPM is, as we are the only authorized ambulatory reseller of this, and probably there is no one else in the United States know the system better than we do. And then there are some of our clients, potential clients in transition, and we would like to welcome them if they would like to utilize the services. So Carlos, thanks so much. So I'm sure we'll ask you to join us again sometime in the near future. So I'm going to ask Tanner to come back, and then we can start our therapy session. All right, so we discussed so many different things in these meetings, and in some cases we have directions in a way that it's pretty clear. In some cases, you, our audience, you may not know which direction we are going, because sometimes we also don't know which direction we are going. So last week we talked about hospital partnership with one of the biggest insurance companies in the state of Delaware. And then I got a couple of messages. Actually, I got 5 messages was asking me to hire security. So they were worried about me. There's 5 different, and then one of them is a business person, 4 of them are physicians. So now that means we are really opening up this issue in a really different way. No one else knows what's happening, and it's my obligation to tell everyone, educate myself first, but educate everyone else, so that we can actually do this in a better way. And then we also know what our role is from United Medical Accountable Care Organization. I have responsibilities for our practices, our providers. So this is part of my job. So that's why we are doing now. I'll tell you guys something very interesting, and in a way it's kind of funny. So last week we discussed part of the issue was hospitals being nonprofits, not for profits. Okay. So, and then how the perception out there that people don't know these hospitals being nonprofit, but then they actually make millions and millions and millions of dollars profit, and we pay as the taxpayers, we pay for this. So now, what happened? And my executive assistant, I finished the session, Tanner, last week, and I shared this with you. So then she said, well, you know what, come on, like, you won't believe what just happened. I'm like, what happened? So then she's like, well, we got a response to one of our surveys.
Mm-hmm.
So the patient surveys from our power chart from our EMR system, Tanner, you actually manage those, right? So you actually send twice a month for patients who have visits with any of our providers.
Yep. We want to look
So
back at
as I was talking about how the perception out there and how people don't know, and this gentleman is 80 years old, and I felt so sorry for him after I read this, because we were following up on his cardiology order, cardiology consult, his PCP in our system, and our care coordinators were following up with him, and he was not happy with that because he says, I do my stuff with Christiana Hospital, not-for-profit healthcare system, who maintains our health records, rather than for a for-profit ACO medical organization. So now he's 80, and then I was pretty impressed the way that he was able to print this, have this typed up, and then he taped it there. And I thank him for sending this, but I also want him to listen to these sessions and then wake up.
We may have to send him some links, Kemal.
So we do. So, you know, in these sessions, sometimes we try to make this a little bit funny in a way. We do this, we do that. Like, I'm going to actually share something with you now. Tanner, I don't know after last week if I talked to you about this specific issue. There was something that I wanted to share, and I didn't actually include it for whatever reason. So you know the term boiling frog?
What was that? Sorry?
Boiling frog.
Yeah.
So let's talk about that a little bit.
Okay.
So I'm just gonna bring that up because I wish I did that earlier. So in my opinion, the issue that we have is the boiling frog issue. You know what I mean by this? Let me actually bring this picture up. So I need to turn this thing off so that I don't get in trouble again. Oh, that's out. And then my email, 1 sec. Okay. So this is actually kind of funny because I use this one for different things as well. I think in politics this happens, in the you know, regular businesses, in healthcare this happens the most. So let's see if our people would appreciate what they see. So if I hear Anne laughing, then I know that this is funny. But I don't hear her. So, well, oh, she's not seeing it yet, right?
No, if you have it up, I don't think we can see it.
Okay, so, okay, that's why she's not laughing. I'm like, oh, what happened? Here it is.
Okay, it looks like it's coming up now.
You can see it, right?
I can see it now, yeah.
So, the boiling frog is
this is
metaphor we use.
Right.
So let's see what it is. So if you would actually boil them in cold water, you start with the not too cold, it's like warm enough, it's not too warm. So then you start slowly cooking them. And then they would not know that they are being cooked. And then at the time when they are boiled, they're dead.
But it's gradual over time, right?
Gradual. And then they're enjoying it. They're having fun. And if there are 5 of them, they're like, oh, yeah, this is great. So look, clean water, this and that. But then that's us. That's the residents of Delaware, in my opinion. So our residents don't understand that they are, I feel like the way that these things are happening around us, Tanner, this is the boiling frog issue. Now, let's actually go to the some of the updates so then you and I will prepped. So my one of my pretty famous lectures that I always talk to people about, perception and perspective. These two things are extremely confused by people. So what I mean by this is that perception is something that is the way that other people understand, the way that they think it's happening, versus the perspective is the real thing. But the perception is your understanding, or this understanding is put out there for you to see. Oh, Christiana Hospital, oh, St. Francis, oh, Bay Health. These are non-profit. They are there for us, so they don't make any money. They are not there for making money. So, well, you have to question why they are losing money. You have to question. Now, first of all, you need to know that these practices, these hospitals, do have their financial records are public because they are non-profit, not for profit. So, but because what bothered me the most was this interference from the hospital. So when someone like Janice Nevin comes out and then say, oh, I'm going to fix the chronic care problems in this state, and I have to say, and if I don't say that, I'm not doing my job, and I do have a backbone. There are a lot of people in different organizations, they may not have a backbone, but I do. So then I will then put this in front of her and then ask her, before you screw our business, please fix your Medicare ratings. This is public. This is available for our people. Now, Tanner, the reason I say this boiling frog is because our patient, just like this gentleman who sent me this letter, is he's not aware of any of these. He thinks that everything is so great. Safety of care is substandard. Readmission is higher than national standard. Effectiveness of care, timeliness of care, and efficient use of medical imaging. So, like when you have these lower than everyone else, what does this tell you is that you are not actually doing your main core business, right? So when you don't do your core business, you don't get to tell me that you are going to reinvent the chronic care management. You're going to stay out of it. So because you don't know what you are doing. So I'm going to share overall comparison. Is it just Christiana Hospital by itself? No, absolutely not. So let's look at from the expenses, right? So Christiana Hospital, this is public, just like any other people. You have to go to your Uncle Google and then find what I'm looking. This is Medicare hospital comparison. You put them, you click them next to each other. I'm not part of Illuminati, so I do not have some crazy access. This is available for public. Use it. So here's our 3 hospitals. I have zero connection with any of them. I do appreciate what they do in the hospital business. We support them from our side as much as we are allowed to. But here's the 3 hospitals. So for example, for payment for heart attack, you remember what you have seen, you saw the quality, right? Why do I have to pay more? Like this 1.03 is that much more for the less quality. So I wish that I could say this name, but this person, but let's call him Mr. Frog. So Mr. Frog didn't actually, 80-year-old, did not check this because he thinks that he's able to do this, then I'm assuming that he's able to check websites. So if you are able to have this high-tech survey response, you should be able to do this. So then look at Bay Health. Bay Health is not better overall, right? So we pay less, we pay more for less overall. So this is why we are maybe a little bit agitated. So rate of readmission. So when you are in the hospital and then you have to come back in 30 days for coronary artery bypass, national average is 12.7%. Christiana Hospital is 13.5%. So Dr. Nevin, focus on your business there. So you need to improve your quality before you talk to outpatient practices. So we are not going to let this happen. Bayhealth is the same way. So now let's look at something interesting side by side again. Christiana St. Francis Bayhealth. So percent of patients who left emergency department before being seen. National average and Delaware average is 2, Christiana Hospital is 4. That means Christiana Hospital, people are in your ED and you're not able to see them twice more than the average. So emergency department volume is very high based on the national standard. Again, this is coming from Medicare.gov. So I don't want one of our other patients to say, oh, he's just sharing like confidential information. No, it's like a public information. So, and then Bayhealth is very high. And then guess what? I mean, Tanner, I don't know, you may remember, or if you read the stuff that I had done in the past, for 11 years, I ran the hospitals program for 2 different hospital systems. I probably hired the most number of physicians in the state of Delaware as a person. Susan Anderson can attest to this. I interviewed more than 500 people in the year 2008 to 2011. So the ED waiting time is something that most people don't understand. So average time spent in the emergency department before leaving the visit is 221 minutes. In Christiana Hospital. That means you are not actually seeing emergency for the because, well, actually they're providing, remember, they're providing service for non-emergency stuff. So then Bayhealth is 224 minutes.
And this isn't then due to a lack of staffing or physicians,
no,
correct?
They are not directing the patients to the right places. They are just giving whatever they can to everyone without filtering them. Like, remember the patient that we had last week? 36 ER visits, Medicaid patients, 36 ER visits.
Right. Now,
in this year, 2021. And then,
Kemal,
go ahead.
I'm sorry. I just wanted, so we're not saying necessarily that going to the hospital is a very bad thing, right? We understand that there are times where patients are going to have to go to the hospital and visit the ED and see, go to these facilities for certain issues that might be coming up. But when it comes down to what we're seeing now and going over the issue of a lower quality of care, and we're going to see that come up here. I know we've kind of played around with and discussed and looked at actual patient surveys that come out for these issues as well, but it's at a much higher cost. And I think when it comes back to the perception and perspective scenario, even what we're seeing with this patient example that we've been brought to us, that oftentimes the perception is going to be that this is the go-to place for our preventative care and for our chronic care management. And that's just simply not the case. So we're not saying that it's necessarily a bad place. It has its own benefits for its respective issues. But I think that the problem is for most people that's how they view the hospital system, as the one fix all kind of scenario.
So that's an important point. So we are not hospital enemies. We are hospitals partners. So our job, our core business is outpatient prevention. But then partnership requires for organic clinical integration. And then hospitals, they have to actually be willing to be part of it instead of trying to be a hero. Because we need the hospitals when we have crisis, when we are not able to manage certain things in outpatient settings, and they're full anyway, right? So, the most amount of money Christiana Hospital has spent is for construction. So they're just expanding. Why? Because it's not enough what they have, right? Sure. So now what I'm trying to explain here is that if we utilize our resources properly, then we know that those people who may need to be in the hospital, they can get a faster, more efficient service.
Right.
And I'm a business person. I have so many years experience. I do consulting for other people. So when I see like this kind of gets my blood pressure up. When I see, this is from a news release. So it's like they want to actually shake up the healthcare system, and then have a reinvent the healthcare. Well, Dr. Nevin, what qualifies you to do that? I mean, your organization record keeping record actually is not showing me that you are qualified to shake up anything, because you are not able to do your core business. Your core business. Now, I'm so sorry for saying this, but your salary went up by 37% in 4 years, but your quality didn't go up. And Delawareans are paying more. Why do you think you are qualified to actually get this chance to shake up the healthcare system? Please don't shake up anything. Just take care of your core business. Focus on your core business. Now, because this partnership is with Christiana Origin, so we are focusing on maybe Christiana. However, this is not different for other hospitals. Overall ratings, Medicare ratings, while Christiana is at 2-star, St. Francis is not different, and then Bay Health is not different. That means all Delaware hospitals. So we have invited so many politicians, and what we actually next time, what I would like to ask them is, are they okay with this, what they see? Why are we okay to settle for less quality? And then you remember our expenses are, what we pay is much more than the national averages. 5 out of 7 core quality metrics they are failing. So I don't think you get to reshape anything. You just need to focus on your business. So this is why we are upset with this. Like, the patient survey rating, they're at 60% patient survey. I have a surgery center, Dr. Nevin, come and visit us and read some of our patient surveys. I'm at 99.4%. So when it's about patient satisfaction, you are failing as well. Your organization, it's nothing personal. Your organization is failing. The difficult part is actually, I don't have any problem with her personally. I do actually kind of maybe even like her as a person. So this is all straight forward business. So you don't have qualifications. You don't. So.
Yeah, I think what you're saying, Kemal, is it goes back to the reason why we hold these sessions and to present this information is because there is a disconnect there between the perception and the perspective of the situation with the healthcare system in the hospitals, right? So if no one else were to do it, then patients, they're going to be sending more and more letters. You have that kind of sentiment with the patients who are kind of unaware of really the lower quality of care that they're getting at this higher price. And it's not necessarily anything to do with the people personally, but it comes down to, this is information that we want to make sure our patients are aware of and our communities are aware of here in the state. It's not just affecting our patient population, right?
Absolutely. So, I have to share one other thing, and then we are going to elaborate them in our next sessions. As a nonprofit organization, now the reason actually I'm sharing this, if we have them in the right order, I saw this news. This is from Becker's, and then it says former United Health. Like, this is not us, unfortunately. So former United Health Group, this is the biggest insurance in the nation and in the world actually, received nearly 18 million in the last year at the company, like former. Okay, so former, I'm like, okay, so if this is important enough, this just came out this week, Tanner. If this is important enough, then how about the former CEO of Christiana Hospital, who received 3.4 million after he left the organization? Why are we not talking about this? Doesn't this have a news quality like the other one has? Like the other one is good enough to be for, it's like, who paid this 3.3 million for the former CEO? He left in 2014. Now, I'm sorry, but this number is like, don't think that I'm just adding the 2014. I'm not including 2014. He got 800,000 after the year after he left, 400,000 after, but he got 2.1 million in like 3 years after he left the organization. That's 3.3 million. Who's paying this?
Yep. Where does that cost come from?
Now, not to mention, Dr. Nevin is at 6.7 million in 4 years. Good job, because she got a 34% increase. For that type of a settled job, you don't get that kind of increase right away, because you shouldn't be, because that's a settled job, settled position. Why are we paying for this? Right? So we have a lot of other stuff that's coming out, and then time is up because we have our CREAS event, our bariatric event, and Dr. Erkan is waiting for me on the other side. So we'll be back in probably 3-4 minutes on the other link for CREAS event. But today, I want our people to understand that we are paying for all these irresponsible expenses. You are paying for all these irresponsible expenses. All I'm doing is to highlight these issues to you so that you pay attention. Your awareness of these is increasing, so then you can question, you can ask the right question, and that's my job. Well, thank you for being with us. Next week, we are going to actually discuss more stuff. Tanner, thank you for being with me in this session.
Certainly.
And we'll be back next week. And we are going to have our CREAS bariatric event with American Surgery Center in the next 2-3 minutes. We should be live. Thank you again. Bye-bye.